Welcome. I'm Dr. Olivia Velez, co-chair of the Global Digital Health Network. I am joined by my co-chair, Rowena. On behalf of the Global Digital Health Network, we are honored to welcome you to the Global Digital Health Forum 2022, our 9th annual and first forum that features a hybrid format. Last year, we had a record attendance at over 1,500 participants from over 100 countries and speakers from around the world representing Asia, Africa, the Americas, Europe, and the Western Pacific regions. This year's forum is set to be more inclusive and feature diverse hybrid format that meets the needs of our global digital health community.
The theme for this year's forum is driving effective and equitable digital health innovations. The COVID-19 pandemic has accelerated digital health innovations. Technologies such as telemedicine, artificial intelligence, enabled medical devices, and electronic medical record systems are just some few examples of digital health innovations. On the other hand, the pandemic has exacerbated the gap in digital health inequalities due to limitations in workforce and infrastructure, among other resources, which are important in evidence-based scaling of proven systems. Indeed, emerging technologies hold promise for better health outcomes. But how do we ensure that these technologies work for all? How do we particularly ensure that they reach the marginalized and vulnerable communities? The network continues to be committed to breaking barriers in digital health innovations. And as such, in this year's forum, we hope to facilitate pathways to drive collaboration, coordination, and cross-country learning within the global digital health community. We look to showcase the latest evidence, successes, effective implementation strategies, and promising solutions to ensure digital health for all, to address global health inequity. We look to create opportunities to review and recognize country, regional, and global progress towards equitable digital health transformation. And we look to strengthen this dynamic digital health community. This year, we received hundreds of abstracts from across the globe, demonstrating how digital health innovations are being used to improve health outcomes. And we invite you to explore these issues over the next 3 days. We have lined up exciting and informative keynotes, plenaries, breakout sessions, poster presentations, lightning talks, happy hour, and technology demonstrations. We also have networking sessions and events that will promote opportunities for you to learn and meet other attendees and other like-minded individuals.
The shift to a hybrid format has also posed challenges. For example, offering sessions in multiple time zones and language. As such, to ensure that the Global Digital Health Forum works for everyone, this year the forum features an ambitious hybrid format, including in-person and equitable virtual engagements. We would like to thank our sponsors for their generous support that has enabled us to organize this event with diverse participation from various disciplines around the world. We are also pleased to have many organizations, projects, and companies exhibiting their latest technologies and strategies. We invite you to visit the exhibitor tables and learn more about their work. We also want to acknowledge and thank our organizing committee made up of the Global Digital Health Network Advisory Council members. Most importantly, we would like to thank you GDHM members, presenters, panelists, and attendees for tirelessly contributing to this forum and for the continued collaborations, network, and knowledge sharing across borders. Thank you for making the network the largest digital health community of practicing globally, comprising over 4,000 members and representing over 130 countries and counting. The network brings together funders, implementers, government partners, researchers, innovators, creators, and changemakers. If you are not yet a member, we cordially invite you to officially join the network by visiting our website and subscribing to our listserv. With that, we are honored to officially open the Global Digital Health Forum 2022. Thank you.
Hi, everybody. Welcome to day one of the virtual Global Digital Health Forum. This is the very first event of the session of the forum, of the entire forum. And I'm really excited for what we have ahead of us over the course of the next couple of days. First, let me introduce myself. My name is Rowena. I'm host of the podcast Aid Evolved, which is the podcast for global digital health. I'm also chief connector at Demagi, which is a social enterprise that builds and deploys technology solutions, and technology lead for McDarrow, a foundation that invests in innovations in global health. Today, we've convened a really amazing set of panelists for you to talk about health equity at scale in digital health. Over the last 10 years in the digital health space, we've seen it's no longer a question of can digital health work or should it be integrated into health programming. We know now that it can work, it can scale. And so the nature of the questions that we're asking has now changed to how do we do it most effectively? How do we do it equitably? How do we make sure that as we're rolling out these programs at national scale to millions of users across a country, across many low and middle income countries, that we're increasing health access and not just increasing the digital divide? Phones are expensive, connectivity is still not universal, digital literacy and data literacy are still much needed gaps in a lot of the populations that we're trying to serve. So what are we doing about it today? What can we do better in future? We've assembled our panelists from some of the largest and most complex countries where we work, including Nigeria, India, and Malawi today, and we'll hear from them in just a bit. We'll be talking about what they learned on their journey to scale, as well as their tactics and tips and lessons learned and challenges in achieving health equity. For those of you that are tuning in today, first, welcome. Second, this is an interactive panel, and you're going to get out of it as much as you put into it. So I would strongly encourage you to ask your questions. Drop them in the chat, include your name and the organization you come from, and tell us, what do you want to hear from this group of panelists? And then we'll be able to get to that once we get into our discussions. So again, just drop your questions in the chat. Let's start off by hearing from Andrew Cross. Andrew, please introduce yourself.
Thanks, Rowena. Hi, everyone. Good morning, afternoon, evening around the world. Really thanks to Rowena for convening this session, and thanks to my fellow speakers and the full audience for taking the time to engage on this really important topic that we're going to discuss today. As Rowena said, I'm Andrew Cross. I'm dialing in today virtually from Bangalore in India. I'm the co-founder and chairman at Everwell Health Solutions. We build out digital innovations, platforms, and systems to support large-scale public and private health programs. We've deployed our open source platform, the Everwell Hub, in more than 15 countries across 3 continents. And every year, our platforms support more than 1/5 of the world's newly diagnosed active TB patients. We also support workflows for HIV, COVID, mental health, and adherence solutions for the private sector. Our most scaled deployment of the hub is in partnership with the government of India's Central TB Division, where we are the technical partners building and deploying NICSHE, the government's digital portal to support TB recovery of more than 2.6 million people every year. Through NICSHE, people can, among other things, review their treatment status, get diagnostic results from tests, be initiated on treatment, and receive support from adherence technologies, as well as financial subsidies from the government, which has exceeded $300 million in direct benefit transfers to people recovering from TB. I'm really looking forward to sharing more of our experiences and answer some great questions today. So really looking forward to that. Thanks.
Thank you, Andrew. Juliet, would you like to go next?
Sure. Hi, everyone. Good morning, good afternoon, good evening. Thanks for joining this session. And again, I'm happy to be part of this panel and looking forward to some really great discussions. My name is Juliet Odogwu. I am the Executive Director at eHealth Africa, and a nonprofit international organization that is really focusing our expertise on strengthening health systems through digital technology and data-driven solutions. At eHealth Africa, we support our government partners and other stakeholders essentially to address critical public health challenges, especially in underserved communities, to bridge the gap really in access to healthcare services. In the last 12 years, we have supported delivery of a large number of programs and projects, primarily in Nigeria and across 19 other African countries, centered around improving health delivery systems, responding to public health emergencies, strengthening disease surveillance systems, laboratory and diagnostics, as well as nutrition and food security systems. At eHealth Africa, we believe that health access should be a choice and not a privilege. And so, happy to contribute to the conversations today around increasing health equity and reducing the digital divide. At eHealth Africa, we're also mostly concerned with strengthening health systems and supporting our partners through a few critical areas. One, revitalizing and strengthening physical and ICT infrastructure, which we really believe is key to implementing data-driven solutions. We also support data management and a host of software solutions, both customized and off-the-shelf solutions, as well as implementing field solutions and logistics-based solutions that go all the way down to the last mile. eHealth Africa also has developed a number of open source global good digital solutions, which include a logistics management solution, like I said, that goes down to the last mile, a data portal that promotes data visibility and information sharing, as well as a digital microplanning and campaign monitoring solution, amongst others. So I'm really happy to be here today, happy to join the conversations and looking forward to a productive discussion. Thank you.
I think Rowena's connection may have dropped, so I'm just gonna, oh, she's back.
Yeah, I was just saying, Simeon, please introduce yourself. And then after Simeon, we'll have Sara. Thank you, Sara. Simeon, I think you might be muted.
Yes, as Rowena has said, my name is Simeon Yosefe. I'm the National Digital Health Coordinator in Malawi. As the title really tells, I am involved in a lot of work, and my work mostly focuses on bringing together various players in the digital health arena. The issue is now to look at who are actually interested partners, or who are the partners who are actually investing in digital health. But at the same time, what is it that they're investing in? How does that really tally with the agenda of the government? Coming from government position or representing government, I have to balance up what the government is really interested in, but what also the investors are interested in. And that's where a lot of tricks come in, because if I don't really probably balance these two up, I end up losing one or the other. So it's quite challenging, because I have to ensure that whatever investment is being made, it's actually made where it's going to make the difference. So we have so much focused on changing how things are done on the ground, because quite for some time there have been a lot of investments coming into digital health, but then not much was really being seen on the ground. So that's where now the issue of establishing the digital health division, that was now to coordinate digital health investments nationally, came in. And the idea now is bring together all these various investments, trying to see where duplications are made and how best can we actually make the situation or use the resources that are coming from the duplicated efforts to actually move to some areas which were neglected. Because I think as investors, when they are coming in, they will always have areas of interest. Now my work is to see how best do we actually address their interests, but also the interests of the government. And that's quite a lot and quite challenging, because not everyone is going to be happy the way you actually direct them on where they should go. But I think with the efforts that we have made the past 2 years, there's quite a big change, both in the mentality, mindset, and also the way investments are being made. I think we'll discuss more as we continue our conversation. Thank you so much.
Thank you, Simeon. Sara, would you like to introduce yourself?
Sure. So my name's Sara Chamberlain. I'm the digital director for BBC Media Action in India, where I've been leading our digital development work for more than a decade. BBC Media Action is the BBC's international charity. Our programs save lives, protect livelihoods, counter misinformation, challenge prejudice, and build democracy. I'm honored to have this opportunity today to present some of our learnings on how to design inclusive digital health solutions. I'm going to start by saying a little bit about Mobile Academy and Kilkari, two mobile health solutions we designed to promote healthy reproductive, maternal, neonatal, and child health practices, and to generate demand for public health services among pregnant women, new mothers, and their families in India. Mobile Academy is an IVR-based training course that refreshes frontline health workers' knowledge and improves their interpersonal communication skills. Kilkari reinforces frontline health workers' counseling by delivering free, weekly, time-sensitive audio information directly to families' phones from the woman's fourth month of pregnancy until the child is a year old. Kilkari and Mobile Academy were adopted by the Ministry of Health in India in 2014, and we spent the next 5 years working together to scale them to 10 million women and 200,000 frontline health workers. In 2019, we transitioned the services to the Indian government and their local partner, Arman. I'm happy to report that they're still going strong today, with Kilkari having reached 24.6 million families in 17 states. A randomized control trial conducted by Johns Hopkins and the University of Cape Town in 2018 to 2019 has found a 7.4% higher use of modern contraceptive methods among those exposed to Kilkari. These effects were even larger in the poorest socioeconomic strata, with a 15.8% increase. Infants of parents who listened to Kilkari were also 15% more likely to be immunized at 10 weeks. According to the WHO, Kilkari is a very cost-effective approach to saving lives. And I'll tell you more about equitable design when we get further into the discussion. Thanks.
Thank you so much, Sara. So as you can see, we have some pretty impressive achievements here. From Andrew, we have a man who's been responsible for digitizing the national TB program in India, which captures 1 in 5 newly registered TB cases in the world. I know Juliet's work has an incredible amount in terms of vaccine access across Nigeria, which is the most populous country in Africa. Simeon is juggling that intense balancing act that you always have to within government of taking all the stakeholders and making sure they play together in a way that serves the country. And Sara has reached, with her work and the work of her team and partners, 10 million women across India. So here we have people who have achieved scale with digital health. Just before I jump into my question, again, a reminder for the audience, what are your questions for this group of panelists, either related to health equity or related to scale? And how do we achieve scale? How do we sustain scale? How do we transfer to government? We'd love to hear from you. And so if you have questions, please drop them in the chat. So my first question for the panelists today is, how do we make progress towards health equity for all, rather than exacerbating the digital divide? Have you seen this arise as a challenge in the work that you've done? And how have you addressed it in your work? And from the experiences that you have, how can you guide others who are also striving to achieve health access for everyone and not just for the most rich or the most privileged? Who wants to go first? I see Juliet has a smile on her face.
Sure. I can kick it off and then, also get others to contribute. That's one of the really tricky things to do, because again, coming from a digital health perspective, and I know there are a lot of innovators and really smart, sophisticated people, even on this panel and in this space, one of the challenges that we typically have is that there's this drive and enthusiasm to create, the most innovative solutions, the most sophisticated solutions, without really thinking about the sustainability in mind and the usability at the same time. And so, I think that's one of the first challenges that we, even as implementers, face, even before we start talking about the health system itself, is really the drive to create the most snazzy tool, the most innovative tool, without balancing that with sort of the usability end of it, designing with the end users in mind, and designing with the system in mind. And you've already touched on some of the challenges within the health system, the infrastructure, the connectivity, the literacy, et cetera. What we usually find is an imbalance or a misalignment, I would say, between the solutions that are developed and the system that they're expected, the health system that they're expected to play in. And so I think that's one of the first things that we must do different if we want to, change that perception or change the longevity or the scalability of a lot of the solutions that we design is really having that as the first thing. The paramount thing is where is the solution planning to be used? And at eHealth Africa, one of the things that we do is develop solutions for the last mile. And because you're developing for the last mile, you have to think about that first. So, is this a system that would require health workers, right, who have very low literacy levels to operate, and in context of them delivering healthcare, right? How quickly are they able to do that and balance all of their day-to-day work? So those are the first, that's the first challenge that we typically find. The other thing that we do as eHealth Africa is we tend to go where the need is, so serving underserved communities, which often means going to the most remote locations. And one of the things that we've done effectively is partner with a lot of researchers who are able to design questions that really help us target where the need is, as opposed to just developing a solution that we can implement in an urban area and that works very well. But when you develop really complex research questions that says what target population is really being missed without these digital solutions or with the current system, and so we partner with a lot of researchers, like researchers from MIT, University of Nebraska, as well as local researchers in local universities, because those are the people who understand the context more. You're able to then design solutions that I would say are best fit for purpose, meet the community's needs, and also take into account longevity and scalability. So I can pause here and let other panelists chime in, but those are some of the things that we consider as we start developing our solutions.
I really like what you're talking about there, Juliet. First, on the design front, I think particularly with how eHealth Africa is positioned, I know you're founded out of Nigeria, based in Kano, and that means that you can do hallway testing. You can work hand in hand with users more closely than maybe other more international partners, although you yourself are international. And that's one thing that has really helped you in your design to make really user-friendly, accessible systems. And then the other piece you mentioned there is on the data side, bringing in researchers. So it's not just a feeling of equity, but knowing as you're reaching out, how many of this demographic, how many women, how many marginalized people are you actually reaching with your interventions? And there's no, then you can't fight with data. So, who would like to go next? Simeon, over to you.
Thank you so much, moderator. For Malawi, it's quite a tricky situation because in my team, I have a team that is developing solutions, technologies, but also coordinating what others are investing in. A little background for Malawi is that there are urban areas where we have quite qualified doctors, or I should say healthcare providers. In the rural areas, in the hard to reach areas, you have very few of them. And in some of these facilities, you would actually probably have nurses managing situations or probably managing the facility. When you go in the communities, we have people who are not medically trained, but they have some sort of formal education, and then they are actually taken on board to help with the aim of having these people live right there in the communities, and for them to actually follow through whatever is happening has not been easy. This is where now partners really felt, oh, we need to probably start coming up with different solutions that these people can be using. But then that also became a complication to these non-medically trained people, because it was like every partner coming up with their own system, which they said, okay, we want this to use this, we want this system to be used by this, and then probably going in very selected areas. Now the challenge was, you could have one area having a number of these non-medically trained officers having support, or probably having 3 or 4 gadgets, each actually representing a partner who is supporting, each one actually looking for their own kind of information that they are looking for, but then they want this to be technologically addressed. Now the challenge was these people were running from one partner to another, just to make sure that they address the needs of these partners. And then the issue of now equal or equitable accessibility became a challenge. Because when the partners are choosing where they would want their systems deployed, in most cases, they were not actually being led by government. But as long as they have chosen that, okay, for us who be working in this kind of districts or in this kind of area, that's it. And then that's where a lot of changes have actually taken place. With the guidance of government, we have said, no. Government has actually to decide where do we really want to go. Which areas have really been neglected? In what way? What is it that we need to push there to make sure that these people also have access to the health services? And that's where now deployment and use of government-led technologies has actually increased access. Because when we talk of now reaching these non-medically trained personnel who are actually providing the health services, we call them health surveillance assistants. We have now ensured that there is equitability. Where people who are actually investing, we actually say, no, at the moment, if you go to this area, there's already someone who is providing those kind of services. Why can't you go in this area? And because of the use of the technology, we have actually made it much easier for the communities to access the services through these mobile deployments or mobile provision of the services. And I can honestly say, with this kind of guided provision of the services, we have actually made the landscape much fair and at the same time much easier for a number of partners to actually come on board. But at the same time, users, healthcare workers, they have actually found it much easier because they don't have to deal with so many requirements by different partners. They have to use the same type of system that we have actually come up with that we have actually deployed to the various places, and it's the one that we are scaling up. With that, everyone is just coming on board and everyone is excited that, okay, this is how we are going. The idea is we want to change the way things are done. Instead of working as competitors on the ground, we want to work as complementers, and this is exactly what we are achieving at the moment. And if you actually come to Malawi, you will be assured that whatever you want to actually look at, whatever you want to address, it will be it's going to make a lot of difference on the ground, instead of probably in some situations where implementing partners were actually using resources for the sake of actually reporting to the donor. We are actually doing these things in a different way, but in a more coordinated way now at the moment.
Thank you, Simeon, for your helpful comments. And it really speaks to the importance of the leadership and the convening power of government, instead of just deploying where we have buy-in from one district to actually look at what are the needs of the country and how do we maximize resources for the country. Sara, would you like to go next?
Sure. So when designing digital health solutions in context where there is a significant gender digital divide, for example, in India, it's critical to adopt a gender intentional approach. Melinda French Gates has defined gender intentionality as identifying and understanding gender inequalities, gender-based constraints, and inequitable norms and dynamics, and taking steps to address them. So why does gender intentional design matter? To quote Melinda French Gates again, development projects that ignore gender inequalities usually fail to meet their objectives. USAID concurs that programs that incorrectly assume that their users or beneficiaries have the required digital skills may set themselves up to fail or deepen the divide between the digital haves and have-nots. Before we designed Mobile Academy in Kilkari in the Indian state of Bihar in 2011, we identified that 51% of women in the state couldn't read or write. Only 18% of women of reproductive age watch television, and only 12% listen to the radio. In contrast to low levels of mass media penetration, our gender intentional design research found that 80% of households and 90% of frontline health workers had access to a mobile phone. However, more than 98% of these devices were basic phones without internet connectivity. Moreover, digital literacy levels were incredibly low, with only 9% of frontline health workers ever having sent a text message. We therefore decided to use IVR technology to overcome the challenges of low literacy and negligible smartphone access. We also designed a retry algorithm that attempted to reach Kilkari subscribers up to 9 times a week if they didn't answer a pre-recorded Kilkari call. Analysis by Johns Hopkins and the University of Cape Town has found that this number of retries is necessary to reach the most disadvantaged subscribers who have less access to mobile phones during the day than better off segments of the population. But even so, after conducting a listing survey in 2018 for the RCT with more than 700,000 households, Johns Hopkins and UCT found that 52% of women did not have access to a mobile phone during the day because their husbands took the phone to work. Therefore, even a digital health solution like Kilkari, which uses IVR technology to reach the most basic phones, risks excluding a substantial percentage of the female population because, as per regulations in India, you're not allowed to make pre-recorded calls at night when the husband and his phone are at home. In this context, face-to-face communication by frontline health workers remains critical to reaching disadvantaged populations, particularly women. When we designed Kilkari, we also created Mobile Kunji, an IVR and print-based job aid that was used by more than 150,000 frontline health workers in the state of Bihar to play social and behavior change communication content to new and expecting mothers and their families. An evaluation of Mobile Kunji by Stanford University has found that the job aid in the hands of frontline health workers impacted a much wider range of health indicators than Kilkari, particularly those that are under the mother's control, for example, exclusive breastfeeding. Kilkari, on the other hand, impacted indicators that are more in the men's domain. For example, the adoption of modern contraceptive methods, which was driven by condom use. These findings highlight that when designing inclusive digital health programs, there is no one-size-fits-all solution. Although direct-to-beneficiary solutions like Kilkari are powerful tools for impacting some health practices, particularly those driven by changes in male practice, assisted access to health information and services remains critical for women. The digital landscape in India has changed dramatically since 2013, and 80% of men and 70% of women are now reportedly on their own mobile phones. But it's critical to note that the digital gender gap persists, with only 26% of women in the country owning smartphones, 30% having used the mobile internet, and an estimated 10% having used social media as of February 2022. In this context, we need to ask ourselves some really tough questions, i.e., is digital health realistic for everyone? My answer would be yes, but only if we continue to recognize the importance of people in the equation, i.e., the frontline health worker, who remains key to our efforts to make quality healthcare accessible to all. Thank you.
Thank you, Sara. Some really insightful comments there about how far technology can go and how far it can't, and how you leverage the in-person piece. Andrew, over to you for the last one, and then we'll take a question from the audience.
Great, thanks, Rowena. I think going last, you've already heard a lot of great comments from the other speakers. I think couldn't agree more with a lot of the comments made about designing for users in context, spending time in the field and measuring what you're trying to impact. So I thought just to give a slightly different picture of things or different perspective, I wanted to talk a little bit about kind of the macro perspective of equality. This is kind of what keeps me up at night often, is thinking about equity across countries. When there's inequality for digital access across countries, or access to tools, or access to funding to support those tools, that can also have a huge impact on equality within those countries. So even when tools are open source, I think we've seen a gross disparity in what different countries are aware of, what they have funds allocated for, or what they're able to nurture and sustain within country teams. So just a few thoughts for there. If we want to encourage or increase the equality across different environments, there's three things that I wanted to share that we could do among many other things. I think one of them is really, advocacy and partnership with governments to help them understand what tools are available and what the most recent data is, to help build out digital health strategies, intentional strategies for how to incorporate digital health into their overall programmatic rules, and also to create implementation and sustainability plans for, again, how to fund, maintain, and ensure equitable distribution across the entire country. I think having awareness and a robust digital strategy are the essential first steps to really having a chance at reducing inequality. I think the second thought is really around financing or sustainability, working with partners to finance, early stage uptake of new technologies, but also to plan for long-term maintenance. I think we've heard this already in the talk today, but maintenance of a digital system is still so misunderstood, and it's a huge impediment to real impact for me, in my opinion. And I think it can increase inequality when you start a system, but it isn't sustainable and therefore it shuts down. I think the ecosystem is very willing to fund new systems or innovations, sometimes in competition with existing tools or maybe unaware of existing tools, but far less willing to plan and fund long-term support of ecosystems or existing systems. So I think that's really important. People tend to think of building an ICT system like buying a car or installing plumbing. There's a large upfront cost, but the expectation is there'll be little maintenance unless something is broken or there's a disaster. But that obviously could not be further from the truth. So I think sustainable funding for these initiatives is critical, very critical. I think lastly is also just fostering an ecosystem of innovators and technology experts to help build out the tools and sustainably work with partners for knowledge transfer or local capacity building to help create homegrown systems leveraging existing tools. Again, open source initiatives are important here, but also investing in local partnerships and building capacity where it doesn't already exist.
Thank you so much, Andrew. Lots of great tidbits in there. We've got questions pouring in now and only 15 minutes. So let's see what we can do with the time that we have. The first question, great one from Liliana coming in, is a challenge I've heard from frontline health workers is that they are overwhelmed by the number of digital solutions. In some ways, the stack of paper registers we tried to eliminate has been replaced by a screen full of apps. What can we do as a community to avoid creating the same duplication we saw in paper systems in the digital side? And I think I'm particularly interested in hearing from Juliet and Simeon, since I know you've done a ton of work balancing all the different apps and how they come together for a particular patient. Juliet or Simeon, who would like to go?
Sure, I can start, and I'm also really interested to hear Simeon's perspective also from the government side, because that's one of the things that we always have to be mindful of, is that we are, as innovators and digital health experts, constantly developing tools and overburdening the system and the government healthcare workers, for lack of a better word, in the race to again innovate and develop solutions. I think it's always a very telling picture when you go into a health facility, even to some of the most rural health facilities, and where you have maybe one health worker who serves multiple roles, and have to find them, having to toggle between multiple systems just to enter sometimes duplicative data sets, to feed various systems. And I think that's one of the things that we have to just change, really, is understanding the landscape, especially at those remote locations where the data input is happening, and coming up with integrated systems that can really leverage one data entry point, as few data entry points as possible, and then share data throughout the system, and then enhance that visibility as you go up the chain. What we don't want is parallel systems where each partner, each donor, is collecting supply chain data, also collecting patient data, also collecting other demographic data at the same time. But they're essentially systems that should be talking to each other or should be feeding off of each other. And so that's one of the things as digital health developers and designers that we have to take into account. The key word here is leveraging, right? So we know that there are already a number of systems that exist in the ecosystem. We've had a bunch of studies that have been done around, or landscape assessments in various countries that show basically the plethora of similar or mostly aligned digital solutions at various stages of maturity that exist. And so for the responsible development, before even going into any area or trying to implement any digital health solution, the first thing that we must do is a landscape assessment, or leveraging one of the assessments that have already been done, understanding what has already been developed, and then maybe channeling the energies into upscaling those, enriching those, as Andrew was alluding to in his point, and ensuring that those existing systems can be maintained. That way, we reduce the impact on the healthcare workers at the end of the day. So leveraging is really important. Thinking of integration and interoperability is also really important. So, an example, when eHealth Africa was implementing the electronic management immunization database, which is basically a database that's recording COVID-19 vaccinations at the healthcare facility, one of the things that we had to build was, interoperability with existing systems to reduce the data burden on the healthcare worker. So, now we have this connected and interoperable with the DHIS2, so it's sending data directly to the DHIS2, reducing the need for the healthcare worker to do that as well. It's also connected to the logistics management system through OpenLMIS that they're already familiar with, and don't have to, again, replicate COVID-19 supply chain data into different system. And so when we do that, when we consistently integrate, we'll basically achieve more efficiency, and then we'll reduce the burden on the healthcare workers. I think in the long run, really having stronger EMRs at the end of the day would really go a long way. I know that sometimes the infrastructure isn't able to support more complex EMRs, especially in rural or underserved areas, but that's a future that we should be looking to, and also supporting the infrastructure that will allow such EMRs and other similar solutions to thrive, because then we can really do away with the plethora of siloed systems that we have at the health facility level. Thank you.
Great answer, Juliet. Simeon, I'm also interested to hear from you, because in theory, the idea of, okay, let's just pick the best one and put it in front sounds really good. But as you know, in practice, there's always lots of reasons to pick every single app out there. How do we find a way forward for the overburdened health workers that we're trying to serve?
Rowena, thank you so much for the question, particularly for the person who has actually asked that question. It's indeed a sad reality that this is what is happening on the ground. Sometimes when I'm actually going out visiting facilities, these are some of the complaints that I get, that we are overwhelmed here because we have these 3 or 4 systems working on the same point, and the person has to move from one system to another just to actually share the information, which could have been shared using one single system. Now, the challenge that we have normally, and as a government officer, I appreciate so much the interest that various partners have, that they would really want to support the government, but at the same time, they also probably benefit from the data that they get from there. I appreciate so much on that. But what is really, sometimes it becomes so painful to me, is that probably a partner comes, says, okay, we want to implement this kind of system. And then you tell them, okay, no, I think here, this is not going to add more value. What if we do it this way? When you tell them that, they actually shun you. They go to the probably direct department, which is actually involved in that kind of work. They say, okay, you know what? We have these resources here. We can actually deploy this kind of system. If we use this system, this is what you are going to benefit. And sometimes the programs are like tricked, because they are only shown the benefits. They are not even told how what complications are going to arise from implementing the system. They end up going for that. But because they have been shown that there is money attached to that, they jump on that. In the end, it doesn't go anywhere. But then time, and then some of such systems are actually in the facilities. They cannot be sustained. They are not actually working. They are not providing the data or the service that they were intended to provide. Now, to address those kind of situations, I know it's not going to be easy, but this is what we are doing. First of all, we actually carried out an assessment of all the different systems that are actually running in the field. We actually got around more than 40 different systems running in the health sector. And you go in the facilities, you'll find 6, 4, 5 different systems at the same point, where a person has to use various credentials to access the system, or to actually change to actually provide the information that is required. I'll give an example of during COVID, when people were actually doing the testing. We had actually come up with a solution that would actually integrate all the services together. But then another international entity comes and says, okay, we want you to actually use this system. And this system doesn't have to actually to talk to any other system. We just want this system alone. Little did we know that there are some sinister issues that they were actually planning, which I would not want to actually talk much of here. But it was really embarrassing to see that things now started coming out on how people were abusing that system, because as government, we couldn't have access to the system. Now, we know, as I said, we know that partners have interests and the developers also have interests, but we should not be compromising the way we want to implement these systems just because we want to achieve our interests. So what we have now done is, as I have said, we have actually done the assessment of all these systems. We came up with 10, and at the moment we are doing systems audit with the idea that we come up with only 3 different systems. And these 3 different systems, they are not like going to work independent of each other. We are going to use the interoperability layer that we have actually developed to make them talk to each other, so that when we are going into the facility to deploy the system, we deploy it as one, and clients do not really know that there are probably 3 different systems that are working together. This is what we have done. And at community level, because we had the same situation, as I have said, that various partners going with their various systems, what we have said is from now onwards, we have one integrated community health information system, which is being led by government, and it's my division that is actually doing that. What we have said to the partners that can we all come together, just check what is in the already existing system. If there's a gap that you feel that you can't really have what you are interested in, can we focus on that instead of you bring completely different system that you should put on the ground? We want to have this one system address the needs of both the users, but also the investors, because when they are investing, they have areas of interest. We want to actually take care of their needs or take care of their interests. So we are actually addressing that. And I have been assuring the healthcare workers on the ground that no, we are addressing these issues. And we are also drafting, we have now a draft policy, which is focusing on the same, on how different systems, new systems are going to be introduced in the facilities. No one is going just to come and say, okay, we are interested in doing this, we are implementing this. That's not how we are working. We are actually redirecting our focus on how best we actually, instead of reducing the workload on these people, the systems have actually, as it has been put, have been adding workload on them. And that did not make any difference. So we are now actually reorganizing ourselves to make sure that when we bring the system, it should really actually reduce the workload that they have and actually improve their efficiency. We are actually moving in that direction. We actually started this drive in 2021, and at the moment we have made tremendous work, and we have started with high volume facilities, and then later on we are actually also moving to the less volume facilities. At the community, we have one specific system. In the facilities, we are actually developing one comprehensive system that is going to take care of all these. So we are really addressing them, and it's a sad reality that these are the issues that are on the ground, and we are trying to clean up the mess. So that's what I can say at the moment. Thank you.
Thanks, Rowena. Maybe I'll just jump in quickly. I know we're almost out of time, but some fantastic comments by Juliet and Simeon there. I think just 2 quick things. I think one was on interoperability between systems, and completely agree. I think one way to do that is to almost mandate any new project or new proposal to do a landscape analysis of existing technology and how you will not replicate or make redundant features that are already there, but how rather you'll interoperate with them or share data amongst those systems. I think the second piece, which Simeon was just mentioning, is almost the capacity of a system to absorb new features. If you think about tools that we use every day, like Zoom or like email client, how many new features do you see a year come on those? And that's because users, it takes some time to adjust or absorb new features. If you keep adding features faster than you can train, then that is actually a disservice to the system. So I think having training, capacity building, and understanding these timelines intimately is a good plan. Thanks.
Thank you so much, Andrew. And with the last couple of seconds that we have for the time, I just want to give a quick shout out to our sponsor, Inkyverse. You can see in the logo over here on this side. They're a creative management agency that works with illustrators, cartoonists, gaming, basically the creatives out there in order to ensure equal pay and representation for marginalized artists. Check out their poster. They have a poster at the virtual poster session over here. And they have some really amazing, beautiful work on their website at inkyverse.world. Enjoy the rest of the conference today, the main stage, the lightning talks, the poster session, and we'll see you in a bit.